Kim Jo-kyu. He is actually an interventional radiologist from Korea. He's going to talk to us about management of type 2 endolytic post-TIVA.
Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. I'm great honor to be here to share my experience about the management of type 2 endolytic after EVA. So as you know, the incidence of the type 2 endolytic is 8 to 10 and 15% at 1 to 6 months after EVA, and less than 10% at 2 years after EVA. So most of the Will you please fix this one? It doesn't work. And the natural history is about the 10% persistent, and the subset causes animal sac growth. And delayed type 2 endolytic associated with an increased number of second interventions. So what is the high-risk factors of the persistent type 2 endolytic? So the patent IMA, the age more than 17 years old, and the maximum diameter of the more than 30 millimeter, and the more than 6 patent lumbar arteries. And if this the factors combination is the risk of the type 2 endolytic is increased. And the diagnosis in the 3-phase CT angio is a gold standard. But around sometimes the patient has a chronic renal failure. We can use in the contrast in the enhanced ultrasound, but they are not widely available. And the contrast is highly operator dependent. And some institutions they use in the duplex sound is most cost effective for examination, and it can be used for the monitoring animal sac growth. The type endolytic, but differentiates, but diagnosis is highly operator dependent in ultrasound. This is the contrast enhanced ultrasound. The specificity and the sensitivity is very high. This is, you can see the color Doppler image. You cannot see any endolytics, but when you inject the contrast material through the basilic vein, you can, after several seconds later, you can see the endolytic is in here. So the ultrasound is cheap and fast, but the contrast material is a little bit expensive. Anyway, the ultrasound is easy to repeat and immediate post-EVA procedures, but it's operator dependent. And if the patient is there's a big belly, that means there are a lot of fat tissues between the ultrasound transducer and the aortic sac. Sometimes it's not possible to do the ultrasound. And the different imaging modality have the varying ability to detect type 2 endolytics. And the second, the sac growth more than 5 millimeter may be more significant in the follow, findings in the follow. In such case, type 2 could be the type 1 in this case. And how we treat it? The embolization should be targeted nice, just like a cerebral and AVM, the feeder, the branches of embolism we have to embolize. What is the embolization? Microcoils and glues and the thrombate onyx, but it's not the proven superior to one agent to the other one. Operator should be persistent and cautious to potentially uncover the type 1 endolytic and type 3 endolytic. And if during the follow-up, the endolytic is persistent, the sac is enlarged, growing after technical success embolization, or when embolization is possible, more aggressive approaches are required, just like a surgical method, laparoscopy, or sometimes conversion to open repair. Endovascular technique are preferred as minimal invasive techniques, and the transarterial embolization is the most common one. The average association rate is 18, and the translumbar is the next one. It's a reasonable alternative, particularly when there's no transarterial access. Okay, let me see some transarterial. Technically, it's challenging, the time-consuming. If the feeding arteries they are very tortuous and they're long, it's time-consuming. That means you have too much radiation to the patient and also to the operator. But the high failure rate, 10 to 8%. Repeat procedures, 20%. High recurrence rate is 40%.